Hi, this is Dr. Jeffrey Roth, your board-certified plastic surgeon in Las Vegas, Nevada, and we are back at it again with another episode of our podcast.
Yes, and you're looking stylish in your jacket.
Well, thank you very much. It's rented. I have to have it back by midnight.
Very
charge
nice.
The
Very
extra
nice.
day, so that's how that goes. They have rentals here in Vegas.
Yeah, exactly. So we just did an episode talking about capsular contraction, and we actually have been getting a lot of questions about other complications related to breast surgery, because obviously that's a big part of your practice, a big part of any plastic surgeon's practice. So let's talk some more about that.
Sure. So yeah, now again, just to be clear, is breast augmentation surgery, again, has about a 98% satisfaction rate on it. People usually really like it. But like with any sort of operative procedure or anything, there's always some inherent risk. So, and we try to manage the risk as best we can, and that's why we also treat it when we can. And that's, again, what you and I have talked about this ad nauseum, is going to a board-certified plastic surgeon.
Right.
In as much as we are trained to handle complications if they arise, but moreover, we try to go ahead and identify those patients that may have an issue or a problem and try to get ahead of those before we
Right, because it's always better to do it before it came, right? Than
100%. Even
yeah.
this last week, as unfortunate as it was, we had to cancel the case because the safety range wasn't where it was supposed to be. So, and there are guys that'll go ahead and push the envelope, and et cetera, et cetera.
Yeah. But this is ultimately, it is an elective surgery.
Yes, at the end of the day, it is not a gunshot wound to the chest. It is not cancer where you have to go quick like a bunny, which gives us the luxury of time.
Right.
We're able to go ahead, and if somebody has funny blood work, we're able to go ahead and talk to their physician or send them to a physician and get it worked up, etc.
Because your first,
we found stuff.
I mean, to say the obvious thing is that your first concern for them as a patient is being healthy,
right,
even regardless of the surgery.
Right. You still get to be a doctor, and we joke all the time that everybody comes to the office, they need a real doctor. Everybody needs a plastic surgeon, of course, but everybody needs a real doctor as well. And then
Sure.
Oftentimes, people coming from out of town will come to the plastic surgeon as their first doctor because they want Botox. And so then they'll say, well, wait a minute, by the way, I need an OBGYN, and I need a cardiologist, and I also need a family practice person. And so we're able to go ahead and distribute them accordingly, et cetera, et cetera.
Right.
And thankfully, there's a lot of good doctors here in town. I work a lot with the Clark County Medical Society, the Nevada State Medical Association.
You were actually president.
Once upon a time, yes.
Yeah.
So past president of Clark County Medical Society, and then still work with them, of course, and with the Nevada State Medical Association as well. And we're really fighting for patients. What we do is patient advocacy, because at the end of the day, there's nobody that's really advocating for the patient to work with the hospital system, or to work with insurers, or to work with Medicaid or Medicare, or to work with
Right.
all these other things. And the legislature's in session, and to go ahead and see what decisions they may go ahead and affect the average.
So it's always going to be patients' safety and health first, and then surgery.
100%. So that's why when you come to me, we talk about your history and physical exam, and again, we had to postpone a patient that they say, oh, I'm on this new med, and the new medicine happened to be a blood thinner. And so, wait a minute, we can't go to do your procedure with a blood thinner. Oh, by the way, why are you on the blood thinner? Oh, the top of my heart was going really fast. I said, did they say atrial fib? I said, yeah, okay, time out, okay.
Right.
Let's go ahead and talk to your cardiologist to make sure that you're safe, et cetera, et cetera. And we find stuff. We found lymphomas before. We found other sorts of cancer before. We find things.
Right.
And so,
because once you go in, then all of a sudden, some stuff's not always seen on X-rays.
Right. So you find stuff, and so we do history and physical. We talk about allergies. We talk about medicines you're on, and that sort of thing.
Sure.
So to try, because again, with the luxury of time, we're able to go ahead and maximize people. So we get our ducks in a line best we can to go ahead and get the best results that we can.
Sure.
And I have no hesitation of postponing or moving the operation to send somebody to a nephrologist, urologist, rheumatologist, cardiologist, whatever ologist they may need.
So, set them up for success.
Set them up for success, exactly right.
So what are some of we talked about a little bit about the list, and we've covered some of that, but let's kind of go over that.
Sure. With any procedure, we always talk about the big three things is the infection, bleeding, anesthesia complication, right? So infection, that's why with me, you get before, during, and after the case, you get antibiotics. I'm a little bit nutty in as much as I lock the door to my operating room so people don't walk in and walk out. And so we do everything we can to prevent infection, which is only 1% incidence, but hey, you do 200 cases a year, that's 2.
And if you happen to eat the 1%,
then it's 100% for you.
Exactly.
That's I had an old professor tell me that too. He said, oh yeah, no, the literature is 1%, but if it's you
exactly. or your mother or your grandmother,
then it's 100% for the right.
Yeah,
So yeah,
exactly.
there's people behind those numbers, right? And so 1% is not 0,
Yeah.
right? So there's that. Bleeding, that's why we check the bleeding cascade before you come in, et cetera, et cetera. Do you have a history of bruising and bleeding? Are you on aspirin, ibuprofen, St. John's wort, and vitamin E?
Aspirin's great if you have certain issues, but it can cause issues too.
Terrific. Yes, absolutely. Like any medicine we have, it's a double-edged sword, right? So, so aspirin's terrific, and especially they're talking about baby aspirins, et cetera, et cetera. But with their pluses is there are also some minuses if you want to have surgery. Again, so usually walking around every day having a baby aspirin, fine. But when you go to surgery or even Botox fillers, they're at a higher propensity to bleed or bruise or that sort of thing. And then anesthesia complication. Anesthesia basically is very, very, very safe. Some people make a big deal about, oh my God, it's general anesthesia. Well, you're actually safer in the operating room getting operated on than you are driving to the operating room that day.
Right.
So in that regards, it's about a 1 in 300,000 chance of something bad going on. Usually to a little old lady that eats saltine crackers and stuff like that, somebody who's not in great shape. But by and large, it's very safe. But that's why I like to have an anesthesia, board certified anesthesia doctor with me. We go to a certified place.
Right. Your anesthesia doctor is just as qualified as you are. They're just as highly qualified.
Yeah. So, and these guys have been with me 18 years, and they've put my wife, my dad, my mother-in-law to sleep, and I like all 3 of them. And that's always the next question. And then the next question is everybody woke up just fine.
Yeah. That's good.
So yeah. So having said that so I make it as safe as possible, and that's actually one of the big questions I get mostly from moms, because moms are more afraid of the anesthesia than they are the actual operation.
Yeah.
And so, and again, after you talk to them and after you get the history and physical done, then you assess risk, and basically most people are at the very small end of the risk assessment. And the anesthesia guys and gals will go ahead and do that. They'll rate it from 1 to 5. Most of my folks are 1s and 2s. They're walkie-talkies. I go to an outpatient surgery center, so typically you have to be able to walk in and walk out of the place.
Right.
And so that makes it that kind of ferrets out a lot of the issues anyways, because you have to meet that criteria.
Yeah, it's always better to catch it on the front end than to have to deal with the circumstances on the back end.
So you have to have that criteria before you're even allowed to have an operation in an outpatient setting. So, and sometimes we have to go to the hospital. There are certain conditions. We did a gal with a malignant hypothermia, which is very long story short. With certain anesthetics, you get really, really hot, and it's not good. And we actually took her to the hospital, and were able to go ahead and get done what we needed to get done. She did great, and kind of hang out in the hospital recovery room for about 12 hours until she went home. And we actually wrote a paper on it and everything. But having said that, yeah, you just have to try, like you said, to anticipate problems before the problems.
What would be the most common issues?
So again, bleeding, infection, anesthesia complications is general, global. And then next is specific to the certain procedures. So, for example, breast augmentation. There's a few of them. There is bleeding, which would be hematoma, right? Oma meaning make a mass of, right? Heme meaning blood, right? So sometimes, and again, very seldom, 1%, but again, do 200 a year, you get 2.
Right.
Not good. We haven't had that. Hematoma is basically where you create a pocket and you put the implant in, but there's a little potential space in there, so sometimes the systolic blood pressure will go up a little bit too high or whatever, and you may throw off a little clot, and then you have this little pump or bleeder. Also, those folks that are on your aspirins and all that stuff, they have less pumpers. They have like this kind of diffuse ooze, and that's kind of more of a pain because you really got to make sure it's bone dry.
Yeah, and because your body is you're doing surgery, your body is naturally going to react to that.
Right. So yeah, I mean, I'm a nice guy, but I take knife to people, right? So
yeah, your body doesn't know who you are.
Doesn't like that, and so it'll go ahead and react in predictive ways, and we can handle it now, ice and elevation, all that kind of stuff. So, but having said that, so that's bleeding. Hematoma. Seroma is another thing, serum, which is the same fluid you have in a blister. OMA, again, a collection of serum. And so in some breast cases, we actually try to get ahead of that with some drains. Again, people don't like the drains. And again, it depends on the issue itself. Primary breast augmentation, typically you don't use drains. Secondary breast revisional surgery or redos or capsulectomies, then you would go ahead and put it in there because you anticipate some oozing, usually not from blood as much as from serum.
Yeah.
So that's the kind of stuff that you would try to anticipate and get a hold of. Capsular contracture, we already kind of talked about that last time around. That's where the capsule, which forms around any thing that you put in the body.
Your body's protective.
Exactly. So whether it's a breast implant, whether it's a chemotherapy port, whether it's a defibrillator, the body will go ahead and wall that off with the capsule. So usually the capsules are nice and soft and people are happy. But sometimes they'll scar in or contract up, in which case, again, sometimes we can do that, manage that conservatively. And sometimes we would have to go back in and do something with the capsule to go ahead and
just have it so it's the most natural feel.
And treat that. Another thing that comes up rarely, but it comes up, is displacement. Meaning, and this happens typically in folks that are real thin or gals and then go really big. And so the implant itself may go ahead and shift in a place that you don't want it to. We see this sometimes after auto accidents. We see this sometimes with other sorts of trauma. Or trauma, and the trauma can be small, but sometimes it's
just
enough.
Happens the right.
It's enough to just tear the pocket, and so now the body will go ahead and repair the tear. But now the pocket itself is bigger, and which allows the implant to slide around a little bit more. And usually it's inferiorly towards your feet, and then laterally toward your arm.
Right, the underarm kind of side boob.
Right. So that's usually kind of where they wind up, because again, chest walls aren't flat; chest walls are curved, and you'll see that with natural breast or even breast with implants. When gals lay down, they tend to kind of migrate towards the armpits, etc.
What would be, and there's a lot of talk about this on different TV shows and whatever, but if somebody wants larger breasts, what's the safety zone? I mean, as far as CCs, is there a range above that you don't feel comfortable doing?
Well, that's a great question, because this last week I put in the largest breast implant that I ever have, which was about 1/3 of what she had in. So this was a very much an outlier case. But having said that, as we went round and round, we talked about all that kind of stuff. To answer your question, for me, there's no hard and fast number. Some plastic surgeons do.
Yeah, but they get straight in the 1,000s, right?
So they make them to 800s. That's the max they make in the United States. Some folks will overfill salines. In the very distant past, thank God, guys would go ahead and stack them, and that's fallen away.
Right.
But again, what's 500 cc's on this little gal who's 5'10" is different than 500 cc's on somebody that's 6'2", and
it also depends on what their goal is, right? Do they want bigger, or do they want firmer, or is it in combination with the lift, right? It's the whole
thing. So they had babies, not had babies, what their skin looked like, had they smoked in the past, have they had steroids in the past, etc. So yeah, there's all of those things, and that's why for me, and again, folks do different things and get good results and stuff. But for me, history is important. History of any medical problems or surgical problems, etc. Drugs they're on, both from
all the complicating factors,
all of it, and allergies, etc., and what they do for a living. Okay,
right.
It's recovery for somebody who's in housekeeping here at a Las Vegas hotel. That's a strenuous job, and those folks work hard, and nurses too. They're pushing and pulling patients and doing all that kind of stuff.
So you have to kind of factor that into the
as opposed to somebody who's maybe a customer service agent. They work hard too, but less physical strength with your pectoralis major muscles, right? So everybody is a little bit different. Can they work from home? How much PTO can they use, etc., etc. So we try to be holistic, if you will, in that thing. Again, trying to line us up for the best result possible.
Right.
So,
yeah, I mean, because a lot of that can avoid a lot of those issues, right? If you do the homework at the beginning.
Right. So yeah, absolutely right. And we have folks who say, okay, well, you need to go ahead and see your cardiologist. Oh gosh, yeah, I went ahead and I had this arrhythmia that they fixed. Now I'm back, and we could do, and so that way we don't have problems. A couple other relatively new things with breast augmentation is breast implant illness, which we've covered a couple times here on the show, where some folks have this constellation of symptoms of malaise and brain fog and tiredness and all that. And by the time they come to me, they've usually been through the rheumatologist.
Trying to figure out what it is.
Yes, and so for me, we take out the implant, we take out the capsule, et cetera, et cetera. And again, I mean, I obviously selected out that patient population, but for me, those folks, 85% of the time will say that, yeah, hey doc, I feel better.
Yeah,
so
I mean,
great, which is terrific.
There's some controversy about that subject.
Yes,
right?
so it's controversial in medical literature, and thankfully now we have folks that are actually doing the true randomized prospective controlled studies, and so we should have more data or better handle on this data in the next, 2, 3, 5 years, so we can actually really kind of delve down. And then what's the etiology? What causes it? And again, can we get ahead of it, and can we prevent it?
I mean, the bottom line is it's about the patient's health. So if they feel like that's the cause, and there's really no harm, no foul to take them out.
Right.
You could always replace them down the road if they felt like they wanted. Most probably wouldn't, but
right. So with me, if you want your breast out, we take them out. So breast implants out too. So that's what that is. And then ALCL, which is basically a very, very rare, thank God, entity where there's basically these cancerous cells, which are the lining of the capsule. To give you an idea of the incidence, is 400,000 women get breast augmentation in the United States. 100,000 of those are reconstructed. Okay? Across the globe, about 10 million people a year get implants. Okay, so that's their number times 20 years, et cetera, et cetera. So that's a big number, right? Okay, so with the ALCL, they've been, at last I looked at this, is about 900 cases of documented certified bona fide ALCL. So 900 divided by 20 million, et cetera, et cetera.
So the ALCL, explain exactly what that means.
Basically, it's they found it in the capsule of breast implants, as well as now they're looking for it, and they're finding it in defibrillator capsules and other capsules as well. So it's basically a change of the cell that makes it look like a cancerous type of cell, et cetera. And yes, there have been some deaths attributed to it, et cetera. So, but it's a very, very rare occurrence, and it really, the line share has more than line share. It has been shown to be in a textured implant, and moreover, a certain manufacturer's textured implant. So, for example, if it's a round implant, according to the numbers as of this writing, your incidence would be about 0. Okay. So now the other is like 0.00001, but there really hasn't been a bona fide certified case as of this writing, and things may change for a smooth implant.
And you guys, plastic surgeons, I shouldn't say you guys, but plastic surgeons, you guys are talking amongst yourselves
all the time.
Yeah, so and American plastic surgeons, ASPS.
Well, there's a couple groups. There's ASPS, and then there's ASAPS, which is ASAPS. But I get 16 emails a day on COVID. I get probably 3 or 4 on breast implant issues, that sort of thing a week. And people are now really studying it. There's an implant registry going on, et cetera. So now we're really trying to get better and better numbers.
Sure.
So
and again, because it's a preventative to avoid issues.
Sure. And again, it's prima non nocere, first do no harm. That's the first thing they go ahead and say to us in medical school. The first thing you do is not harm your patient. Do something harmful. So having said all that, so ALCL is something that we're looking at, and the line share that was in a certain manufacturer, and they're all good. So Sientra, Allergan, Mentor, it's like Coke, Pepsi.
Right, the majors.
They're all good. They've all gone through extensive testing. It's basically the most tested thing that we put in the body, believe it or not, because of all of the things that go with it. So having said that, it's the textured implant, and the one that had the most aggressiveness with it seems to be the one with the most incidence of it. So what I think is going on, again, with I don't have a lab to go ahead and back this up, is I think that the inflammatory situation with the aggressive implant probably went ahead and transformed or somehow affected these cells, et cetera, et cetera. So that's where you actually get the the recall, which it was a terrible thing to call it,
yeah,
because recall sounds like, you know, I got to get my brakes redone, you
Right.
know, and go back to Ford and just switch out. In fact, the FDA said, you know, you do not have to get them taken out, right?
But just be more aware.
Right, to just be more aware and you know, et cetera, et cetera. So having said that, but what happens is people on their feed says, you know, implants, cancer, and they stop reading, you know, and then they go ahead
Yeah.
and then they call. And so
Which
call
is,
me,
in a way, it's
right?
understandable.
Right, which is right, absolutely right. And so, but if there's a question like that, yeah, call me or call another board certified plastic surgeon, and we're like, okay, sure, this is kind of how this works, and yes, come in if you want, etc. So by all means, we plastic surgeons,
Yeah,
are
and
always
maybe
around to
if they
answer
have a
questions.
concern about that, find out what implant they actually was put into them,
Sure.
the brand, and if it was that or
Sure.
surface.
So everybody gets their little card, I call it a little membership card.
Right.
When you get an implant device, and most people will have them in a shoebox somewhere, but some people move 3 or 4 times and
Sure,
get lost
yeah.
along the way. So, but if you have that information, or if you're getting implants, try to go ahead and put that in a safe place.
Yeah, I mean, and with any procedure like that too, if you start feeling like something doesn't seem normal, call your doctor.
Absolutely. So call a doc, and so, and that was kind of been a big thing during the COVID thing, is if folks didn't want to go to the doctor and folks didn't want to go to the hospital, and folks died at home of a heart attack because they
Right.
didn't want to go to the hospital.
Or they come by the time they show up, it's too late.
Right. So by all means, if there's an issue, and that goes for diabetes, that goes for hypertension, that goes for all the other stuff that docs take care of. By all means, if you have those, go see your doctor.
Right.
Basically, at this point, everybody, well, I'll speak for my office, everybody in the office has been vaccinated, et cetera, et cetera. And we take all the steps you're supposed to take, and all the other doctors' offices that I know of.
Health first, surgery second.
Right, right. Take care of that, and then even go to the ER. They segregated off the COVID units for the not COVID units, and the COVID part of the ER for the not COVID. So while sure it's in the back of everybody's mind, if you gotta go get help, go get help.
Yeah, and you've actually, I mean, even with what's happened this past year, you've still been doing surgeries. It's just,
well, yeah, we shut down for
I mean, for a little bit you did,
for 2 months, and then we really, for us again, like most people, nobody's in the waiting room anymore. We call you from the car, a text. We have a lot of FaceTimes now.
Right.
We have a lot of virtual consultations.
how is that, you know, and actually I was going to ask you about that. So how is that for you? How does that work with the virtual consultations?
Well, I mean, for me, I think it's great for the patients, and especially if they're getting certain procedures done. And we always get a lot of, hey, do I need a breast aug versus a lift? And usually we can discern some of that. I was taught a long time ago by a family practice physician that the patient encounter doesn't count unless you touch the patient. And he's right.
It was a different time too.
Oh, right. So you have to be there, examine. And so there's some things like, again, some folks can come in or we can see over the phone or whatever for abdominal, right, or Zoom, from a abdominoplasty. But still, I want to put my hands on and say, oh, do you have a hernia or not? Right?
Sure.
So those are those sort of things. And when we go ahead and we talk on Zoom or Skype or whatever they set up for me, because technology challenge, but is all of a sudden, oh, there's a patient there on the screen. And so basically, for me, it's, you know, absolutely you can go certain farness to it, but you also have to give the prerogative of eyes on, okay, this is how we're planning it, but you do still have to come in, and I still have to go ahead and really examine
it's
it.
good just for the initial meeting.
And do that stuff.
And in Nevada too, and we talked about this the other day, is actually we have a lot of rural communities.
Yeah, so we, especially the Medical Society, have talked about rural medicine for forever, and getting specialists, especially to go out to Yerington or Winnemucca or Jackpot or Caliente,
Or these little towns in the middle of nowhere, essentially.
all these places, and you know, how do you get, you know, people out there, and especially if it's and there's great docs out there, but sometimes you need a little more of a specialist, etc. How do we get them? Otherwise, you know, get in the pickup truck and drive 8 hours to Reno.
Right.
I mean, that's a haul.
And also, if you're talking about
Especially for
reconstructive surgery, if you live in those towns, you'll have general MDs, but you probably may not have a plastic surgeon.
Yeah, so it depends on the size of the town and what they're doing, et cetera, et cetera. So the thing is too, and especially sometimes for medicine checkups, you know, that kind of thing. Do you really have to, you know, haul 8 hours in and 8 hours out to get your medicine checked? So we doctors have been talking about that for years, and I think that one possible silver lining for The COVID thing is that that's probably something here to stay,
Right.
and there'll be a certain platform on it which will be HIPAA compliant and all that kind of good stuff at some point. But I think that's probably the final push to go ahead and make that work.
Yeah. When you do, so you do surgery, I guess 2 times a week, right?
Yeah, typically right now we're doing Tuesdays, Fridays, and so those are our days to do that. They've proved pretty popular.
Yeah, and we were talking about music in the operating room.
Yes.
We were talking about it. So tell me a little bit about that story.
So I'm sitting in Las Vegas, right, the entertainment capital of the world, and I'm sitting in Marks and Rex the Space and everything. So with all
which is a great place.
Which is a terrific place with all this Broadway stuff and everything else. And then I'm sitting here with multiple musicians. So I'm not musically inclined. That all went to Jack in the family.
It's your brother. So
kazoo maybe, triangle, I don't know. So that's as far as I dare to go. The shower is where I'm sitting. So yeah, but oftentimes guys will go and gals will go ahead and play music in the OR, and it's funny because usually and people ask this. But you can't have it distracting, and I guess it's low enough, and I turn it off if we have to, etc. So never a distraction. And there's some folks that got really. There was one dermatologist who was like dancing in the OR, something like that. I just,
now we got our TikTok doctors, right?
Right. Please. And so, and there's some good guys on that as well. But that platform. But yeah, I mean that's the one. I have to tell you, the OR is the one place which is really kind of like sanctuary or a cathedral or something, because my phone goes off. You can't.
No, you have to. You can't have distractions.
No, you can't have distractions. I can't think about anything else. They're running the business, et cetera, et cetera. So that all goes away, and I get to concentrate on one thing.
Yeah.
And so that's really kind of.
And that's, I mean, really, like it seems like with you, that's your happy place.
Yeah. So that's we talk about
that's your art. That's your art.
Yeah. So yeah. So that's a place that I've been trained to do what I do in judgment and everything else like that. And so yeah. So having said that, usually it goes towards Eagles, something like that.
The playlist.
Classic rock. Well, there's a few guys that actually had playlists.
I was gonna say we should actually do your Spotify playlist.
And made mixtapes. Shout out for mixtapes. and so for those of you youngins that are listening to the program, so a mixtape is when you were in the 80s and 90s and we were on cassettes. Right. Yeah, okay, you can ask your parents about that. 8-track was in the car. But anyway, so if you liked a girl, you would go ahead and make them a mixtape, which means you would wait by the radio. For me, if you didn't have enough money to actually buy the music. So you would wait by the radio, and the song came on, and you would click on play, and you would go ahead, and then you wait for the radio for another cool song that you wanted. And so then you would find the gal at school and go, hey, I made this mixtape for you. and that was kind of cool back in the day.
Selling your mixtapes on the playground.
So and then you would sell that. So actually, it was this Dr.
You could have been DJ Roth.
So that the way things are going, you gotta have a side thing. So actually, Dr. Rapogel, shout out Dr. Rapogel if he's listening. He's not gonna listen, but he was a plastic surgeon, so he would make these CD mixtapes actually of stuff he liked, classic rock, this, that, and then he would give them out to his friends and everything else like that.
Funny.
So and he would call himself Dr. Reptile because of Rapogel.
It's funny too. Like everybody thinks of doctors, and obviously you have a lot of training on the serious job, but doctors are human too, right? They like to have fun. They like to enjoy music. All that stuff.
And there's actually believe it or not, there is a medical orchestra here in town, and there's some really good players. From strings.
They were the smart musicians that they went to college.
And again, I'll just say shout out to Dr. Michael Seif, who is a phenomenal brain surgeon. Wow. He's a neurosurgeon. And I think he would rather be playing keyboards someplace some days. And he's phenomenal at that too.
But it's nice to have that release, right? Because you have a high pressure job.
So you have the left brain and right brain, and such. And we know that music cross applies, and I'm preaching the converted here as people are looking at me. But so usually it's a classic rock, Eagles. Although I don't know how Motley Crue got to be classic rock anymore, but it's because I'm just getting older. But having said that, it's usually that. Usually if you're with the resident will go ahead and pick out the thing. I don't have residents in the room anymore. Yeah. But for lipus, and it also depends on the day. Meaning, then we have nurses that go ahead and they have the EDC stuff, whether it's drum and bass or house or whatever like that. So yeah,
we've gotten off on a weird tangent.
And then my surgery tech will go ahead and say, "Can I have something with lyrics?" You know what I mean? So yeah, so it really kind of depends. It also depends, you know, who your anesthesiologist is,
Sure.
etc. But having said all that, is something that is kind of flowing. Is some guys like classical music. Steve Talabom, a shout out to Dr. Talabom, who's phenomenal plastic surgeon. He likes classical music in his OR. I was in an OR trapped in an OR where I should say that, is where the surgeon loved Patsy Cline, which is great.
Funny.
But
7 hours.
Yes, every day. And she's great. You know, crazy. I thought, but yeah, I mean,
too funny.
So again, it kind of depends on the what's going on. For example, liposuction, you usually want something kind of up tempo, you know, kind of thing.
High energy. We do the liposuction.
Right. So yeah, you want to have that a little bit, and then for microsurgery, you usually want kind of calming, you know, Vivaldi. Four Seasons is really good. We like that. Yeah. And a shout out to Dr. Gabe Kind, who's up in the Bay Area. He's a very kind surgeon. He gets that all the time. But he's a phenomenal microsurgeon. And when I was training, he was at the Bunkie Clinic, which is just an absolute phenomenal place. And the late, great Dr. Bunkie, he invented microsurgery.
Wow.
And probably the nicest guy you ever wanted to meet, and always there to be helpful and push the envelope. He was just a spectacular guy, and his son took over, and they just do phenomenal work. But so Gabe Kind is basically is there are moments in the OR where things get a little difficult, and especially when you're doing really, really technical surgery, and especially microsurgery, where you're putting
very intense.
You're using suture that's finer than a human hair under the microscope, and you put two vessels together, and they're supposed to connect and be able to have blood flow, and sometimes they don't. And so you take it down and you put it together, and it's supposed to connect and flow, and sometimes it doesn't.
Right. So
sometimes it can be very, very frustrating. And again, you're working under a microscope, and you're next to the whole thing, but you get done. But there are those moments that are a bit frustrating. So the thing was put on Al Green, and so for him, Al Green, you know, was able to kind of, you know, all right, let me think, let me get this out. Is there a certain way I can do this? Blah blah blah. And so if you walked into the OR to tell Dr. Kind something, and the Reverend was on, not the time to talk. Okay, but
that's funny.
Okay. I'll be back.
Do you think, is there a certain like psychological profile for surgeons? I would think there's a certain kind of people that really gravitate towards that. I don't know.
Depends who you ask.
Right.
Yes, would be. I'm sure my psych friends would go ahead and have a field day.
Because that is a lot of pressure
on this. The whole thing again. It comes down to, you know, helping the patient and using your knowledge base and hands to go ahead and make a difference.
Right.
And for that, I think that's the common thread. And then and again, surgeons are different too in the type of surgeon. There's the trauma surgery guys like to rock and roll. There's the you know,
we always think of like the MASH.
Right, the pituitary adenoma guys. There's the guys that like to do really fine things with thyroid. There's the microsurgeons. There's the orthopedic surgeons. Now there's the orthopedic hand surgeons that do microsurgery. And then there's the orthopedic surgeons who just love big, bad, ugly trauma with bones sticking out and pelvic stuff and everything else like that. Well, yes. I mean, so with the orthopedic stuff, I usually assist those guys, but some guys like, you know, really big, bad, ugly, you know, fractures, and some guys are you know, more erudite and everything. So again, even amongst that specialty as well. So
when you go to school for plastic surgery, do they? I guess at some point, I mean, do you always? Most people always know what they want to specialize in, or
that's a great
kind of figure that out.
Yeah, you kind of figure that out on the way. In medical school, or first of all, you go to medical school, right? So that which ain't easy to get in, right? So. At one, and then two is okay. Then at some point you have to make a decision of where I'm going to be a surgeon or not surgeon, right? So am I going to think or am I going to cut, right? So right, and the best doctor is an internal medicine that can operate or a surgeon that can think, right? So And then there are some folks that are hybrids between the two. Cardiology now has gotten more and more invasive, so they're thinkers, but they're now being more doers.
Right.
OBGYN, same thing. They do, if you want to call it internal medicine or family practice stuff, where they can manipulate hormones. By the same token, they're surgeons.
Yeah,
and so
there's more expected of them.
Right. So there's and they're doing it on no sleep because they've delivered babies all night and everything else like that. So I've got a lesson.
Right.
So having said that, there's that, and then so once you get into surgery, are you into neurosurgery or plastic reconstructive surgery or general surgery or trauma surgery, or there's all different aspects of that, and so.
So some people are just drawn to certain things.
Yes, and for the first year, internship year, they give you a little Whitman sampler of everything, and so I like that, I didn't like that, etc. And so again, where you're being trained, and the personalities in the department may have you push one way or another,
Sure.
or the operations themselves may push you one way or another as well. So it's interesting how you eventually get to where you are. But hopefully it's in the room of medicine that you really like. And I tell the medical students, there's lots of rooms in the house of medicine. And some are big rooms and some are little rooms. And some have lots of light and some have little light.
And you have to kind of find where your lane is.
Right. And you try to go ahead and figure that out. So I tell the medical students and interns to see as much as you can do. Go ahead and take that rotation on something that you probably never would have thought. And they go, oh, well, that's kind of intriguing. Or even if you never do it again, well, hey, you did a couple, 3 weeks of rheumatology.
Yeah, you try it out and see if it fits.
Yeah, if it fits. Or at least you'll have that knowledge base,
right.
So you can understand the language and the nomenclature, understand where these guys and gals are coming from when you call them at 2 in the morning.
What was your, did you have a medical background in your family? Are there other doctors? Are you the first one?
No, I've been, how far you go back up the family tree.
Well,
right, and insert family tree joke here. But no, our mom was a nurse, and she was an operating room nurse, and awesome. she tried to dissuade me multiple times
because she saw that whole
here's what you're getting into, son.
Right.
So of course, like most kids, I didn't listen, and pursued medicine and surgery and plastic and reconstructive surgery. So yeah, that was kind of basically it.
That's great. I mean, obviously somebody you look up to. I mean, that's not an easy job, right?
Oh yeah, no, absolutely. and with our mom, she phenomenal. We'll start there. But she would go ahead and scrub in cases, but then they had her be head nurse, and then she went and got her master's, and then she wound up running the OR, and she was really good because she'll say, fine, I'll go ahead and scrub in and do this case, which kind of, for an administrator to go ahead and do that would kind of, and she knew what her people were all about and what they needed.
Because she had worked her way through the system.
Exactly right. And as a matter of fact, which is odd, is getting into Cedars-Sinai Medical Center, which is this big monolithic,
globally known,
internationally known teaching hospital. And so they were redoing, I think it was the 8th floor up there, and so she was the head nurse, and then so they were going to go ahead and do this whole central processing thing, which is where you get the sterility from, and the instruments go there, and you make them sterile and pass it. And she says, no, you guys are doing it all wrong, and you got to put this over there and this over there and this over there. And they actually listened to her. Awesome. And they did it, and they went, oh my God, you're absolutely right. And when she passed away, my mom, they actually put up a plaque for her, which they never do at Cedars for anybody who's like less of chief.
Because they've had a lot of
chiefs of staff. If you're not chief of staff, you're like regular, you get a plaque, right? And so for a nurse to go ahead and get a plaque up next to her room over at Cedars, was phenomenal. It's there this day. And then when she went to Midway Hospital, which is now Olympia Hospital in Los Angeles, and she passed away. They did the same thing as the medical staff got together and got her a ridiculously large, big plaque that put up in the on the entrance to the OR. So if you had to go to the OR, you had to see her every day. Yeah. And which again is just unheard of. Yeah. But that was the
that's so proud for you. I'm sure for you guys of what she accomplished. I mean, Cedars-Sinai is a globally known hospital. That's amazing.
Yeah. So that's the impact that that she had. And again, coming from the bottom up and knowing what people actually need and what's not needed, and then she could tell administrators, no, you don't need that. We don't know.
Yeah, and we had that discussion the other day. Like people, I mean, you basically did that too. You put yourself through school. You worked hard to get to what you do. Yeah, that helps you respect everybody that you're working with.
I was very lucky. I got scholarships. I worked hard, but I was very fortunate, blessed. And then people made a couple of wrong decisions and let me into programs. And all that. But no, I was. We've talked about this. I was an ER assistant at Brigham and Women's Hospital, which is part of the Harvard system, which again was phenomenal.
Right.
And when I was in college, and they did the first, a lot of firsts, but one of the first transplants there was a kidney on an identical twin. That way you didn't have to worry about immunology so much, which was done by a plastic surgeon, by the way. But it's another story for another. So anyway, so a phenomenal place. And I was the ER kind of orderly. I did the stuff the nurses didn't want to do. And so I would do stuff like delouse patients.
That's a fun job.
and all that. So, and clean up. And I was the guy with the mop.
Right.
And yeah, okay.
But
so,
doesn't that make you really, like now, like we were talking about that now, it really makes you appreciate people that have, because it takes a whole team to make that all work.
No, 100%. If the guy pushing them off doesn't get there, I can't do the next case. If the guy not cleaning the instruments isn't there, I can't do the next case.
Right.
The nurses especially, if they don't do the stuff they're supposed to do, if the tech that didn't come in, the EKG machine doesn't work, I can't do the case of anesthesiology. Yeah. So it's very much a team effort.
And getting back to what we were talking about with the complications, all that stuff, that having that team doing all their jobs at a high level avoids a lot of those issues.
100%. And it's a team effort. And again, that's why you put policies and procedures in place, not really dumb ones, but ones that actually make sense, that protects the patient and that allows everybody to do their job. Because again, at the end of the day, it's all about the patient.
Yeah, and about the best outcome for the patient.
Absolutely right. So,
tell us, our audience, how they can find you, and if they want to do a consultation, how they can reach you and all that kind of stuff.
Sure. So we're very available in as much as we are on the web at www.jjrothmd.com. And there's lots of really good information on there. We're also all over social media with Twitter and Facebook and Instagram, and also this podcast, which is all on the really good places to find your podcast, which is your iTunes and your Podbean and your Spotify and all the other places.
Mixerbox, Amazon Music. It's a long list these days.
Yeah, so it's getting long, which is good. Yeah. And so yes, tell your friends. And again, if you have questions, by all means, please go ahead and call the office or get us on our social media platforms, because we actually do look at them, or on our website, because we look at that every day. And by all means, if there's a question or anything that you want us to raise, let us know. We love questions.
Yeah, and I should actually have this, because I actually work with you with your social media. So Dr. Roth does actually answer all the questions as well. I mean, as you can on Instagram, on those formats. So you are talking to him, and you can ask questions. We get a lot of people asking about consultations and different subjects, right? So.
Absolutely. So by all means, and again, I would rather you spend 20 minutes with me than 20 hours on the internet.
Exactly.
So if there's a question, by all means, come in. We'll take a look, etc. Also, basically, we are completely Spanish speaking as well, so that shouldn't be a barrier. So by all means, if you have somebody that Spanish is their first language, we got you covered.
Yeah.
And so by all means, if there's ever a question or concern, call and ask.
Absolutely. Thank you, everybody, for joining us, and we look forward to talking to you on the next episode.